eConsult Coalition Roundtable meetings. If you missed our first one, we're happy to get you up to speed and get you our last meeting materials on our eConsult Workgroup website, which we'll talk about later in our presentation today. So we'll do a quick recap of what our coalition is all about. We're so pleased to have guest speakers today from UC Davis Health, Drs. Avdulovich and Marcin, who will be speaking about provider perspectives on eConsult. We're also excited to announce the expansion of coverage of eConsult to the uninsured. We'll talk a little bit about that. And we, as part of our work group, like to provide resources to those who are participating in eConsult, including continuing medical education. So we'll talk a little bit about our CME program we have set up to address behavioral mental health needs for eConsult. We've drafted a patient tool so that providers can talk a little bit about eConsult with their patients, and we'd love your input on that. So we hope we can have an open communication and dialogue around patients' needs for eConsult. And we have some exciting events to announce to you, so we'll talk about those at the end of our call today. I think we have everybody in from our waiting room. I encourage you to participate in the chat. I know we have a good number of people on our call today, so we welcome your Q&A, any comments that you'd like to share with us using chat. And we'll take a break for Q&A after Drs. Avdulovich and Marcin do their presentation too. So thanks for your participation. So we'll take a moment just to welcome you all. We have a good number and growing number of provider organizations who are participating in our group. And so I'm not going to read you this long list because we're just so excited to have so many people on our call today. If you don't mind just taking a moment, if you are on actual Zoom and video, if you could use the chat just to quickly introduce yourself and your organization, that would be very helpful. And I'm just doing a quick scroll of any new names that I see on our list here. If you are not able to get on Zoom and use chat, you're welcome to unmute yourself and introduce yourself if you're new to our call today. I'm going to call out Dr. Kim. Thank you so much for joining us. I believe you're with Crib. Dr. Kim, thank you so much for popping on our call today. And to the Chapa Day team, Alana Stevens, Dr. Stevens, thanks so much for joining us. We're going to talk a little bit about you later today. We have Erin from WellSpace. Thank you so much. And Nicolette, if you don't mind introducing yourself, which organization you're with, that would be perfect. And our ConfirmEd team, we're so glad to have you all. And of course, our UC Davis team, thanks for joining us today and speaking. And Dr. Austin from Northern Valley Indian Health, thank you for joining us. Nicolette from Novano. And we also have the group from Ampla on today too. So please do use that chat to share questions as we continue talking about how we might be able to best help you to engage your providers at your organizations. Just a quick snapshot of some data that we've gathered over time from programs that have worked with us as part of our eConsult work group. A lot of people join this call wondering what eConsult is. So when we started out gathering people as part of a coalition across North rural counties, we wanted to offer tools to providers to better engage them in eConsult and support them to be able to use this to improve access to care. Some quick data that you may have seen before, just to be able to talk to your other provider peers about eConsult and why we would do this. We are seeing across the country that through using eConsult, providers are able to see response times improved, getting specialist advice with typically within 48 hours as part of our program. We're able to address that backlog in specialty care that so many of you are facing, trying to get your patients into specialty visits. Those of you who are doing eConsult have noticed, you can see that unnecessary face-to-face visits are reduced. So many of our eConsults result in patients being able to get the advice that they need without a face-to-face visit. You see some great data here. Over 50% of questions that are asked via eConsult have been addressed without having a face-to-face referral. As part of our program in North Rural and Central Valley, we're seeing almost 80% of eConsult requests being resolved without a face-to-face visit. So it's amazing to see. I remember talking, and Ampla, I don't want to call you all out, but a few years ago, I sat with you all and you said, often you had to triple book telehealth visits because no-shows were so hard to manage and telehealth was so hard to manage. It's just great to see that through eConsult, face-to-face no-show visits have been reduced throughout the country. It's great to see. We're going to talk a little bit about provider satisfaction today. Great data around primary care provider and specialist satisfaction for eConsult, and patients. We want to talk about patients and members. We'll do that a little bit later as we develop tools to better talk to patients about eConsult. We want to also be able to help providers to think about and talk about with their referral teams, how do we approach eConsult? So what we've used as sort of a mantra for those who are beginning this process is, how to engage in eConsults. We know that eConsults are not for every referral. So we've started to try to use this term that we use eConsult as the first step to a specialty referral for all routine, non-urgent, and non-procedural referrals. And that's been a way to sort of simply categorize this and make it easier for providers to understand. And Mark Schweier, Karina Mendoza, I'm not sure if you want to add anything here in terms of the plans approach, how you see eConsult. Would you like to pipe in?
Yeah, Libby, thanks.
Yeah.
So this has been important to us for a number of years. We've been engaged in this effort since 2016, about mid-year, and have really concerted effort towards scaling this across the state. We've got a lot of very high-performing organizations that are engaged in the program, and we really think it provides a great deal of value for our members, especially during the COVID and wildfire, disasters going on, with just getting early access to specialty care. So I'm really happy that everybody's here and really excited about moving forward.
Thanks, Mark. Karina, go ahead.
Yeah, this is Karina Mendoza with Anthem Blue Cross. Hi, everyone. I've been working closely with Libby at Blue Path Health and other payers like with Mark and over in the north. So I would just like to add on to what he was saying that, eConsults definitely has significant benefits to both the primary and specialty care providers. So using eConsult as a first step to a specialty referral really advances the quality improvement, patient-centered care, and characteristics of high-performing primary care. So we definitely really encourage that eConsults are used as a first step for non-urgent, non-procedural referrals. Thank you.
Thanks so much, Karina. We wanted to share just a couple quick snapshots of what an eConsult looks like. And before we launch into our presentation from our UC Davis providers, and I welcome Dr. Anderson, Marianne, Agi, and team to comment here. A lot of folks are wondering, what does an eConsult look like? And so we just grabbed a couple of quick screenshots from the ConfirmMed team that show that this is simple and follows the provider's referral process, including clinical information, a question from the primary care provider, and then ending up with following the referral pattern and transmitting the information from the primary care team to the specialist who answers this question remotely and asynchronously. And Dr. Anderson, I'm not sure if you want to make any quick comments on just the flow of eConsult, anything that you'd want to add here?
Yeah, no, I think thanks, Libby. The most important thing that this is trying to show is that from the PCP, that our workflow and our implementation process emphasizes each PCP ordering the consult within their own EHR environment. So these are actually screenshots from specific EHRs. The one you see here is actually from ECW. But I think one of the things that we found is it makes the process much smoother and easier for primary care providers if they can order the consult out of their EHR without having to adopt a different workflow, logging onto a different website or something like that. And so these screenshots basically show that. The first one was a screenshot from within the EHR where they were documenting their visit, ordering a referral. The second one shows sort of the back-end process of a referral coordinator or a nurse routing that consult to ConfirmMed.
Thank you so much, Dr. Anderson, for bringing that up. And we appreciate the ConfirmMed support and clinical examples of how this works within the clinic's referral process. So we really appreciate you joining our call. So now I want to get to our featured presenters for today, since we do have Dr. Avdalovich and Dr. Marson joining us. It's been great to have UC Davis supporting and educating around eConsult for the past few years and being involved in our eConsult work group. So I'll let you introduce yourselves. I'm so glad you took the time to join us today.
Thanks, Mark. I figure it would make most sense if you were to go first.
My pleasure. Thank you, Jim, and everybody, Libby in particular, for inviting us. My name is Mark Avdalovich. I'm a pulmonary critical care physician, and I've been involved with our internal eConsult program here at UC Davis for quite some time. I'm vice chair of medicine, and I lead our ambulatory telehealth tools that we have available for our physicians. Jim, I think you've made my slides more pretty, so actually we'll go back to that first one. I do not have any conflicts to disclose as related to eConsults as far as I'm aware, and if I had some conflicts, I wish that money would flow more efficiently. But so next slide. So I'll give a little bit of background in terms of how UC Davis's internal eConsult program has been constructed and how it's grown a little bit. You know, we have been part of many of the eConsult work group meetings in the past, and so we are a little bit different in terms of our workflows with regards to eConsults. The history is that approximately around 2014, 2015, UC Davis was part of a 5 University of California UC Office of the President initiative to grow eConsults as a matter of improving access to specialty care within the UC health system. Our eConsult program is built on a platform of REHR, which is Epic, and it is slightly different than other eConsultation programs are administered from a workflow standpoint. And that difference is highlighted that it's the dealer's choice on the primary care side. So the primary care physician decides up front if they want an eConsult or an in-person visit. And then based on that choice, an eConsult order is created, and that eConsult then flows to the specific specialists that would then review that eConsult request. At that time, the eConsultant, the specialist, has the option to obviously answer the eConsult and perform a full consultation. They also have the option to ask more questions of the primary care physician if there's not enough information available within the eConsult question and the links that exist to the patient's EHR in terms of requiring more info. So this could be perhaps the patient had an outside CT scan for which the image is essential, and the specialist might ask for access to that image before deciding to answer as an eConsult. The specialist can also just decline the eConsult outright. And particularly early in the program, this actually was an issue because occasionally what we would deem kind of inappropriate questions would flow through as eConsult questions, such as how do I order oxygen for my patient? Which are really more, you know, referral administrative questions, not a consultant level question. And so, but with education, we were able to get over those hurdles. Of course, the final option for the specialist is to decline to eConsult because they want to see the patient in person. So the eConsult is a distinct order within our EHR for every single specialty. And for some specialties, they have distinct eConsult orders based on symptoms. So there can be an eConsult order, for example, just for thyroid questions. And there are some advantages to building it that way. We approximately have about 30 different specialties performing eConsults at this time in both the pediatric, surgical, and medical specialties. And I would say that the biggest change that we've seen in the last year, separate of course from the pandemic, the biggest change is that the transition with CMS to recognize this work as interprofessional consultation and provide work RVU credit for the work. We've shifted our compensation model for our physicians from a internal incentive program that was paid as a bonus to the specialists for performing these to now just being part of their regular work because they're directly billing for their procedures, for their consultations. And so I think that kind of summarizes the background. Next slide, please. I think I reviewed most of this. Let me just make sure. Yes, so we covered all of these. And then, of course, the final part of this slide is that occasionally we do complete an e-consult and the patient still needs to be seen in person. And I call that e-consult recidivism. It's not whatever the correct term is. It's not legally linked to me. But that is our concept, that an e-consult just wasn't sufficient to answer the primary care physician's question. And so that's an important data point that sometimes is hard to get at, to be quite honest. Next. So this is a snapshot of our eConsult orders, not necessarily completed eConsult, but the orders generated by referring physicians, which for a long time was only primary care doctors. But as of November, once the CMS rules went into effect, now we are not limiting eConsult orders to primary care physicians only. Specialists now can send an eConsult to a specialist if they want to. And what you see here is this very interesting, I know the slide is rather small, so I'll walk you through it. This is 3 years worth of data. And just prior to the pandemic starting in March of 2020, our dermatology group had felt that the dealer's choice with the primary making the decision for eConsult was not as efficient as they would have liked in terms of improving access for their specialty care. And they felt that if an eConsult first option, that means that the primary care physician had no choice in the matter. They had to order an eConsult first. And then some of those were converted to in-person, but many were answered as an eConsult. That would create access in their clinic. So you see this huge increase in eConsult orders, and that is almost exclusively, the increase portion is almost exclusively because basically Derm made it mandatory to order an eConsult every time you wanted an input from our dermatologist. And in fact, they were correct. Their wait times for in-person visits decreased from 39 days, these are working days, to down to 8 days during this period of time when they had this huge increase in eConsult referral orders. But interestingly enough, even though patients got to their questions being answered more quickly and more efficiently, and those who really needed to be seen were now getting seen very quickly compared to historical times, there was actually a lot of dissatisfaction on both the patient and the primary care side, which was it was an interesting kind of conundrum, almost like not being happy about taking the medicine that makes you feel better. So patients were upset that their choice was taken away, and the same way the primary care physicians wanted a little bit more input in terms of what they feel is more appropriate for an eConsult versus in person. But then November came and the CMS rules changed, and if for those who are not aware on the phone call, one of the portions of the CMS rule change that is very important is that if you as a specialty choose to answer a question as an e-consult, but then you end up seeing the patient in person within 2 weeks, that in-person visit is no longer a consult, it's a follow-up. And that created, from an incentive standpoint, some disincentive on the dermatology side, and that coupled with some of the feedback that they had received in the previous 4 to 5 months resulted in them changing their workflows, and they went back to the way every other specialty was conducting their e-consult programs. That is, that the primary care physician has the first choice. And so what you see here is that the e-consult orders leveled off in these last 7 to 8 months, and we're averaging around 300 a month across those 30 specialties. And again, the leading specialties for us at UC Davis are still by far dermatology, and then some of our medical subspecialties, in particular infectious disease, as you might imagine, and then endocrinology is always very high. Next slide. So prior to the pandemic, our response times were actually very consistent and reproducible. Month to month, if you looked at how long a specialist was taking to asynchronously answer an e-consult, it was averaging about 1.8 working days. I will say that once the pandemic came, for a variety of reasons, those wait times for an answer became much more unpredictable. We've had 4 surges within our health system that have, occupied the health system with regards to COVID. And during those surge times, the wait times for specialty specialists to answer an e-consult started to drift closer to 3 days. But then it would come back once we had less COVID to deal with. Interestingly enough, as well, during COVID, one of my other jobs is I oversee the clinics for the Department of Internal Medicine, so all of the specialty clinics. And what we saw was a very unpredictable availability pattern. That is, that during the summer of 2020, we had a lot of availability in clinic to be seen in person. All of a sudden, patients just did not want to come in person. We had a lot of open slots that we could get patients in quickly. And it became such that e-consult was a less attractive way to see a patient when you can see them. I mean, in my pulmonary clinic, believe it or not, in the latter parts of the summer last year, I could get a patient in within a day, which is unheard of. And so we had these ebbs and flows of availability of in-person space. And I think that definitely contributed to some of our e-consult ordering patterns. So even prior to the pandemic, again, if you answered an e-consult across all the specialties, so some specialties this is not as true as others, but around 15 to 20% of answered e-consults eventually needed to be seen in that clinic if you looked at a 6-month forward-looking analysis. That is, I performed an e-consult on a pulmonary patient, and they still showed up to see me for the same question within 6 months. We considered that a failed e-consult visit, even though I don't think it was actually failed, but that's the category that we chose to label it. And again, depending on the specialty, if you look at eConsult orders, so the previous slide where I showed that there was around 300 eConsults per month at this point, if you look at those, it depends on the specialty, but anywhere from 30% of those orders to as much as 60% of those orders are still converted to in-person. And again, every specialty is a little bit different. I find that dermatology still is very efficient, that when they get an e-consult order for derm, it almost always is answered first as an e-consult. So they don't have that much of flipping to an in-person. whereas other specialties do seem to flip a little bit more frequently, like some of our surgical specialties will do so. Next slide. Thank you. So after all these 6 years, what have we learned from this? What are the consistent sort of pros and cons that we hear? And I broke it up by looking at primary care, the specialty point of view, and of course the patients. Primary care has always felt that they really enjoy the quick turnaround. The patient care staying with the PCP has also been a very attractive feature, particularly for primary care physicians who, you know, are a little bit farther out from central Sacramento. For them, the ability to manage the patient's care when you're 40, 50 miles away from the med center is attractive, so that the patient doesn't have to travel. And the time to come down and be seen in a specialty clinic in Sacramento was taking, you know, anywhere from a month to 2 months to be seen. And also many primary care physicians felt like through the process, they were learning more about a particular disease, which is one of the things that with the program we tried to emphasize, is that when you're answering an e-consult, to take the time to provide a little bit of like a teaching point, if you will. So the most common e-consult for my practice for pulmonary medicine at UC Davis Health, by far, I mean, and nothing comes close, is management of pulmonary nodules. So I have a stock little insert that is part of every one of my e-consult answers for pulmonary nodules that walks the primary care doctor kind of through the pulmonary nodule differentiation process. So we tried to include some of these learning teaching points as part of our answers, and many of the primary care physicians felt that that was advantageous. The specialists also definitely felt that it improved the access for their more complex patients. That was both their perception, and in reality, wait times for many specialties decreased as a result of e-consults. So some specialists also felt that this improved their connection with the PCP, and even though some might think that e-consultation sort of decreases the amount of referrals that you might see from a particular primary care cohort of physicians, for some specialists, they felt that e-consult was their conduit to opening up a conversation. I call it breaking bread with your colleagues. And so that ability to initiate some quick interaction, quick communication around a particular specific patient, then results in that primary care physician being more comfortable in sending more consultations. So in some ways, e-consults for certain specialties seem to grow their practice, although we don't have objective evidence of that because there are many variables that were present as part of that process, changing of physician workforce, et cetera. From the patient side, we had multiple patients, particularly early in the program, extremely happy with this option because they got their answer fairly quickly, whatever it is that the symptom related issue was. And in particular, since the 21st Century Cures Act, I've had several patients share with me that they like the fact that if I send an e-consult and 2 days later the specialist answers the e-consult, all of this is viewable to the patient through their EHR portal because of the 21st Century Cures Act, because all of our notes have to be shared with the patient immediately. And so now they see these consultations, whereas prior to the 21st Century Cures Act, the primary would have to share the answer either through an EHR portal or through a phone call with the patient, what the conclusions were of the e-consult consultation, the recommendations. And so from that aspect, the patients have been very satisfied. Next slide. In terms of the cons, this is because of the pandemic, things definitely changed. and not necessarily because of the eConsult workflow, but just the nature of the pandemic and the problems that it introduced. Primary care physicians still feel within our internal program, one of the things that they struggle with is they forget to order the eConsult. They realize it would have been a good idea, but they've seen the patient's left, and they go, oh man, I should have just done an eConsult. And in order to address that, we've taken the strategy of taking all referral orders and making them a panel order, so that if I order a consultation to cardiology, there's a panel of eConsult, in-person, and if in-person is telehealth okay, that sort of thing. We've tried to introduce these panels. Unfortunately, with the way our EHR currently works, if you saved your favorite orders for referral as a personal preference list, it's hard for us to pull that off of your preference list because it's your personal list. We don't necessarily have administrative access to all of it. So we're slowly in the process of purging some of these legacy orders so that all orders will be in a panel order. But this is a system-wide process that'll take us a little bit of time to complete across the board. eConsults are still driven by the few. If you look at the approximately 190 primary care physicians that are part of our primary care network, the eConsult ordering process has primarily been driven by around 25 to 30 individuals out of those 180, 190. And it's really, the numbers are quite sobering when you see how much those few are driving the entire process versus some of the ones that only order an eConsult once every 4 to 6 months. That's a challenge for us. We've taken several approaches. Prior to the pandemic, we used to do a bunch of brown bag sessions to try and engage individual pods of primary care physicians to help see the value of eConsult using their own champion colleagues. So at each of our primary care sites, there's typically 1 or 2 physicians that order a bunch of these. So then when we would all get together and talk about it, those 1 to 2 would try and impart their enthusiasm for the program and how beneficial it has, so that the other 4 or 5 in that location might think about it a little bit more frequently. And so that's been one of our interventions. Primary care physicians have also complained that from certain specialists, the answers are not always robust. And I'll speak to that in the following way. As the program director over eConsults, I've not been as prescriptive with my specialists on how they have to do this. In other words, if they had 2 or 3 champion specialists that really wanted to do this, I wanted to take advantage of that situation, of their enthusiasm, their willingness to do it, and I've let them do it as a 2 or 3 person group. I've found that that's been the most successful strategy because you have enthusiastic people who really like to do it and they do it well. Other specialties have felt like that's too much to put on 2 or 3 people. So they've divided the eConsult work across the entire workforce. So if you have a specialty group that has 30 individuals, they each take a turn at answering eConsults. And frankly, some of them just want to get the answer over with, and some of them spend the time. So when you have this more diverse group within a specialty, it becomes a little more difficult to maintain a certain quality standard. And as our eConsult numbers have grown to 300, 350 orders sometimes per month, it's a little harder to corral how an individual specialty is staying within certain standards. So we've actually used our billers, now that we're billing for this, to look for components in the answer that we feel are essential, and then providing appropriate feedback. From the specialty side, coverage equity has been an issue. For some specialties, only 1 or 2 people are doing these, and it can be really tough. When you have hospital duty or you're on vacation, you have to sort of find coverage for your specialty to do this work. And so we're hoping to improve that situation. Specialists have also felt that, although this is less of an issue now, but certainly early in the program, that sometimes the question quality was somewhat poor. And so as we've had more consultations within a particular specialty group, we feel that the question quality from the primary care physician, from the ordering physician, has improved and has become less of this curbside level of interaction and really much more to the level of a real consultation. And I would say the primary con that patients see, or they relay to their ordering physicians, is that many patients just still want to be seen in person. And that is a important thing for them. And so eConsults is not for all, and those who have choice want the choice to be seen in person. Next slide. I think we're done. So Jim, I know you have some slides.
Yeah, I don't know. I'm having, if there's questions here, thank you so much. And I don't know if it's better to have questions here, or I can try, why don't I try and be quick if that's okay. Thank you so much, Dr. Argalovich, for those great comments. I'm not trying to throw lob questions to you in the chat, but I have some.
I'm going to go ahead and start answering some of them while you're doing your thing.
They're mostly for me. And again, so thank you so much for that overview. So I'm Jim Marston. I'm a PEDS ICU doc. And so I am not like Dr. Argalovich in that I'm doing these routinely, but because I do inpatient medicine. But I did want to talk about our Department of Pediatrics, where our specialists are doing these kind of e-consultations, I'll say externally, if that makes sense. What Mark had gone over are within our electronic health record and our primary care clinics and specialty clinics located throughout the Sacramento region. So we're all on what he's talking about is all on the same EHR and all quote unquote UC Davis providers. And so our Department of Pediatrics, our specialists here, because we serve a very large area, have begun to provide e-consultations in two ways. One is to a direct agreement with the health plan, where the health plan can come to our specialty groups and say, hey, can we have you provide e-consultation services to our network of primary care providers. Then of course there has to be some platform to be able to do this. And then we've also done an agreement with folks that are on this call here, a direct contract with a service provider that kind of has it packaged. And so they're the intermediary between the health plan and the specialty providers that way. And so our department has done it in both ways. And I just wanted to kind of make a little bit of lessons learned, and again, perspectives from our provider, if that's okay. One is that because it is not integrated into our existing Epic, Dr. Anderson had mentioned that he's worked with primary care providers to have this integrated in their electronic health record so that it's easy for them. It's not yet fully done on our end. So our specialists are getting notified and then kind of log into this another platform to be able to do it because it's not in our Epic, right? We don't have a medical record number for these patients and things like that. There's reasons that it's done this way. So for our providers, we have to, if we're going to agree to do these, we have to work with another platform, and it's not as easy, streamlined as it is when we do our internal e-consultations all within Epic. The other thing, I'll kind of go to the bottom when Dr. Argalovich mentioned how we credit our specialists now with work reviews and things like that. And that's a little bit different now. So how is it? And it's different under different circumstances. We can say, hey, to our specialists, hey, we'll give you RVU credit for this. We did this before the CMS change. And so what we were doing was we were collecting a dollar amount from the health plan or the service provider, and then kind of passing that on to our specialists, if that makes sense, with a tiny departmental task. And again, I don't know if there's a right answer to the way to do this. Do you give RVU credit? Do you have the money go to the group of providers, or do you put it right into the pocket of the specialist who's answering these questions, right? And so if you ask a specialist, of course, a lot of them say, hey, well, why don't you put that money in my pocket? Which sounds great for the specialist since they're the ones that are doing the work and that's incentivizing them. But for the practice group, if that makes sense, all of a sudden that one practitioner is seen as kind of like moonlighting, if that makes sense, right? Because they're doing the extra work for the extra pay, but in a way that might or has the potential to take away or make them more busy from the group's perspective. And again, so whether it's RVU credit, financial credit to the group, directly to the doctor doing it. Again, there's pros and cons with each of those, and I'm happy to answer questions, or at least with our experience with that. Then the other thing, again, Dr. Abdalovich had pointed out some of these when we're talking about providing an e-consultation, and there's a relationship being built between the PCP and the specialist. I think that there's some value, or specialists see some value with education and giving a comprehensive response to that if they know that they're going to be building a relationship. That way, if that PCP says, oh, that's Dr. Sarah Haynes or Dr. Jen Rosenthal or something like that, they're going to see that they might recognize that name and they were very helpful to me in this e-consultation. I might refer a patient to them. When you're talking about doing these e-consultations to patients that may not be in your referral region, perhaps the specialist is a little bit less incentivized to go the extra mile to provide education, resources to the primary care provider if there's no possibility of that patient ever being referred to them. And again, so our specialists are happy to do that, but it's just something that's coming up where some of our specialists really would prefer to limit the e-consultations within their geographic referral region, again, because they're investing the time to build these relationships and thoughtful responses. And if they're outside the region, but then we have specialists that are open to doing it outside our region as well, again, because in our model, they're being paid for it. And so I think I just tried to make some notes on this. And those are the comments that I wanted to address talking about our quote unquote external e-consultations. And so that's it, Libby.
Oh, thank you so much, Dr. Marston. I think it's so helpful to have two different perspectives on this. And the great thing about your two presentations here was that you covered all the questions that I had asked here in discussion. And I welcome those who are on the call today to use the chat to share any questions for our UC Davis team that's on. But as people are thinking about their questions, maybe you can just share your last sort of final takeaway. And my biggest question for you all is, what do you suggest? Obviously, UC Davis Health is different than engaging a primary care provider at an FQ, but what might you suggest to the clinics who are on today as to how to engage a primary care provider in doing this?
So I'll start. I mean, I think in our experience, it comes down to a few things. Number one, I think oftentimes primary care physicians told me, and I would say this is the most common feedback that I received. They would say, Mark, I like the concept of e-consults, but I just forget to order it. It's not in my head at the time when I'm seeing the patient. And so building a process in where there's almost like a decision support that allows them to either remember, hey, this is an option for an e-consult, can be helpful. That's number one. Number two, for many physicians, whether it's primary care or specialty, with this idea that we're managing things asynchronously and without the patient physically being seen is still a hurdle for us to get over. And probably less so after COVID or during what we've gone through in the last 18 months. But still, it's not, everybody is of the opinion that being seen in person is always better. And I would actually propose that getting the correct answer quickly is the most important. And if that's in person, awesome. But if I really need an answer and I can get it in a day versus waiting 8 weeks to be seen, I think that does make a difference. And so building on those type of themes, I think can be helpful. Also, if the specialists go out to these primary care practices, we found that that was helpful as well early in the program, when the specialists would make an actual physical visit to the clinic and talk to them about e-consultation.
I'll just add, if I may, again, but would love to hear others on the call, their perspectives on this. It's like asking, it was pre-pandemic, asking folks to use telemedicine, right? And I think the COVID pandemic forced us all to do it, probably opened our minds, and now we're saying, hey, there is a right time and a place to be able to do these video visits. I wish the same thing could happen with e-consultations. Now, I do what experience with LA Care or something like that, or our dermatology department where it was forced. Again, that's not always the best thing. I'll share this story. I was talking with the dermatologist, and what happened was some of the PCPs, with being forced to do e-consults, said, well, then if I have to do an e-consult before I provide my patient, and then they were sending these crappy pictures of people's rashes because they had to do it to get a patient to be seen. And so now they've backed off, but part of me probably thinks that was a good idea, because it at least forced them to learn how the process worked, and its reluctance with change management and their normal priorities. But I think once most of the people try it and use it, that they will find benefit of it. It's just trying to get that that adoption curve going. And Mark, I'm so sorry, I tried to say, you had mentioned that sometimes there's crummy quote unquote questions from the PCP, but can't the orders be in such a way that there are questions that need to be answered during an e-consultation?
That's a great point, Jim. And so I spent a long time in the beginning making sure that I matched the way the order is done so that the specialist has the elements in it that they wanted. And some primary care physicians figured out that they can sort of delete all of that and just say, patient's short of breath. And that's all they'll put in. Then you have to kind of sift through the chart and look at their previous note, like, well, what's the actual question here? And so that's the primary care physicians figured out a way around the bumpers, so to speak.
It's so helpful. And I think we have a couple of pieces here that sort of weave into your presentation in the next few slides. I'd love to have you weigh in because your perspectives will be helpful as we talk a little bit about patient engagement. But I really appreciate your time today. And I think we may have some questions that come in by chat. If anybody has any that we don't get to today, we can share them with Drs. Avdalovich and Marcin. We hope that you can stay to the end of our call, but we understand if you're busy too, seeing patients, and we really appreciate your time today. So thank you so much. So I have some quick material to cover. It's nothing as interesting as the UC Davis presentation, but I do have some thank yous. And first of all, I know that we have Dr. Stevens on the phone today from Chapa Day. I don't know if Scott is on also, but we want to just take a moment on our monthly calls to thank those who've been active and doing eConsult for a while now. I'm not sure, Dr. Stevens, how long you've been with Chapa Day, but I've known that your clinic's been doing this for a few years, and we appreciate your commitment to this and really spearheading this across the North State too. So any comments just on your experience, Dr. Stevens?
Yeah, thanks. I think we've been doing it for 6 years and have definitely grown through that process. We actually have kind of defaulted most of our referrals to eConsult first, and then there are specific ones that you have to pick that way. And so we've kind of been building that. Scott is one of our FNPs who utilizes it and is a champion, like Dr. Marcin was describing. So he has definitely been a big lead and a force in championing it. And we also have Debbie Arve here on the call as well, who kind of leads the referral part of the process.
Oh, thanks, Dr. Stevens, and thanks, Debbie, for joining us. And it's definitely such a team process working between primary care and referral teams. And Karina, I know that we want to acknowledge the clinics that are participating. And Karina, do you want to note sort of what our spotlight involves?
Yeah, thank you so much to the Chapa Day team for all that you're doing to increase utilization of the e-consults. So we would definitely love to, or Anthem would love to award you and your health center just with a gift card so you guys can all get lunch for the referral team and the providers. So I'll be in contact to connect with you and provide that gift card. So thank you so much.
That's sweet. Thank you.
Thank you, Anthem and Chapa Day. I have a few other announcements to make. This one is a great one. As some of you may have heard on our last call, we had a CME session in conjunction with ConfirmEd around pain management. A couple of months ago, we had 80 people on it. So obviously there are certain specialties that are in high demand and scarce supply that we really are noticing our pain points across our state. One of them is behavioral mental health. And we feel this, of course, you all feel it specifically around the crises that you're facing with COVID, with fires, with just I'm sure just a big stress on many of your patients. So we're happy that we can offer this CME for providers who wish to get this credit. It's also open to those who just want to listen in on effective eConsult for mental and behavioral health. November 9th is our date that we'll be doing this. We have a UCS team, Dr. Petra Steinbuschel, who is experienced in doing both phone and eConsult for psych. So we're looking forward to that. Please mark your calendars for November 9th, and we'll send out a registration link soon. We are also excited that starting in October, we are going to be able to extend eConsult access, not just to our California Health and Wellness and Anthem managed care members, but also to uninsured patients. So we're collaborating with Central Valley Health Network to be able to extend this to you all and to your patients that are uninsured. So that this will be easier for your primary care providers to offer this to both Medi-Cal and uninsured patients. A couple of other things that we've been thinking about. And at our last couple of calls, we've heard that providers need better tools to be able to talk to patients about eConsults. So we've drafted this up. We welcome your comments on how you might use a patient-facing tool. Those like Chapa Day and others, you may have these kinds of tools if you'd like to share. We're welcome to take your input and feedback. We're trying to use some simple language to be able to make this accessible to patients. Maybe a leave behind for a provider or something that you leave in your waiting room. So we welcome your comments with regard to what patients need around how providers and patients are talking about eConsults. So please send your comments our way. And also, we want to make it clear to everyone that we've been talking a lot about primary care engagement on this last call, and we do want to encourage those of you who have specialists who might want to participate. Obviously, Dr. Marson and Dr. Gweldich spoke about how specialists are getting engaged. If you have providers at your clinic who are on the specialist side, we'd want to engage them in this program too. So please do share with them the opportunity to get involved. And big events are coming up in the next month. I've already mentioned our CME, but in addition, we have our eConsult Work Group annual meeting. This brings together organizations from across the country, not just California, to talk about eConsult. This event is once a year. It's on November 2nd and 3rd. November 2nd focuses on telehealth. November 3rd is focused specifically on eConsult. So this registration link that you have here, we will make sure that you get that. You'll get multiple reminders from us to register, and it should be on your calendars for November 9th. And I'm just zipping through my announcements. You should be getting an email every month that has publications, published data, studies around eConsult and its effectiveness, announcements around new opportunities for you like CME. Those will be in your email inbox. And if you're not getting this from us, just let us know. Please feel free. You have my email address likely if you're on this call, and you can let me know you're not getting the newsletter. We'll make sure you get this that has important information on a monthly basis. And lastly, econsultworkgroup.com that you can see here has all this information in it. So we'll get over to you in our chat the links to our eConsult work group and our North Rural focused page on our eConsult work group website too. Mark, Karina, any words in closing today? you might be on mute.
Just if you're interested in signing up for the eConsult program and getting started with implementation, please let us know. Thank you.
Thanks so much, Mark. Karina, anything else you want to add before we wrap up today?
Thank you. Just thank you to everyone that joined the call today. I appreciate the presentations as well. It's great.
Great. And Dr. Marson and Dr. Aldalevich, thank you so much for joining us. We really appreciate your time and all the work that you've done to grow this over the past few years. You've really provided some great examples of how to engage providers. So thanks so much for your help. And we hope everybody has a great day. Bye-bye now.